Ladies and Ladies and gentlemen, please take your seats. Our program is about to begin. Ladies and gentlemen, please take your seats. Our program will begin in 1 minute. As a courtesy to others, please silence all noise-making devices. Thank you very much.
So now this is the big results. So I don't know if there'll be a drum roll or applause, but we'll try it out. Oh my gosh, there really is a drum roll. Wow. So after that drum roll, over 3 million fewer harms and adverse infections over the past 5 years. Approximately 125,000 lives saved and over $28 billion in cost savings. So seriously, give yourselves and all the people you represent a round of applause for that.
I like to think about the difference between an implementation gap and a knowledge gap. There are important knowledge gaps, but there are also implementation gaps where we know what to do, but we're not doing it. And stroke is a good example of that. Of all of the strokes that occur today, most of them, about 45%, almost half, that is, could be prevented just by better implementation of the simple, clear tools we have available.
The point was made very well that we still have lots of opportunity for improvement. I was particularly struck by the opportunities to improve cardiovascular risk factors, to reduce the leading cause of death and disability in the United States, and health disparities.
We also know that collaboration is necessary. And we talked about the patient safety goal that we've achieved and the huge success. 87,000 lives have been saved because of the work and the commitment you've shown over the last 4 years.
There's so much synergy between what we are asked to do with providers in terms of correct antibiotic prescribing that also applies to correct opioid prescribing. And the synergies are going to help us really get the outcomes that we need to get.
What I'm so excited about as I think about this current program cycle is the coordination of care communities. I think when we look back in 5 years or 10 years, that will be the lasting legacy of this program cycle.
Ladies and gentlemen, please welcome Dr. Matthew Press, Director, Learning and Diffusion Group, CMS Center for Medicare and Medicaid Innovation.
Welcome to the third and final day of the 2016 Quality Conference. What an incredible first 2 days we've had so far, and today promises to be just as exciting. I'd like to spend a few minutes recapping some of yesterday's highlights and giving some reflections and previewing some of what's to come. First of all, I'm pleased to report that during day 2, the CMS Quality Conference was trending on Twitter and was the 47th most popular hashtag in the entire United States. And speaking of hashtags, my favorite tweet of the day was in the upper left-hand corner from Dr. J. Bott. Too loud? He said, quote, "This is hashtag awesome sauce," in his tweet about the exciting safety results Patrick Conway announced. Yesterday morning, we also heard from Dr. Kara James from CMS and Mary Smith from the Indian Health Service discussing the critical importance of quality improvement in vulnerable populations and those experiencing disparities in care. One of the key aspects of care coordination and safety, as we all know, is at the primary care specialty care interface. And Mary Smith talked about IHS's innovative use of telemedicine to improve access and quality in this area. She also mentioned the IHS's new dedicated QuinnQIO, which we're all very excited about. So these results were so #AwesomeSauce that I think they're worth repeating. And on Monday, many of you received plaques celebrating the 87,000 lives saved. In fact, Kara James, in her speech yesterday morning, talked about 87,000 lives. And then just a few moments later, Patrick Conway gave the update of 125,000. So that shows the tempo of change that we're all experiencing. 21% reduction in healthcare-acquired conditions, 125,000 lives saved, 3 million fewer harms, and $28 billion in cost savings. So in all seriousness, these are, as Patrick said, these are real people, real families whose lives are being positively affected. It's your work, and we thank you for that. Give yourselves another round of applause. As Patrick said yesterday, though, while we've made tremendous progress, there's still work to do. There are still harms occurring, and we need to continue to eradicate them. Similarly, on the payment side, Patrick talked about the tremendous progress that we've made, reaching over 30% of Medicare payment through alternative payment models. But there's still progress to be made there as well as we strive towards meeting 50% by the end of 2018. As Patrick said, we have to work, quote, we have to work harder to get people on the pathway to quality improvement. And the goal, as he discussed, the goal of the QPP is to make it easy for providers with a range of experience in new payment models and quality improvement to get on the pathway and evolve along that spectrum. I think there's an integral connection between quality improvement and payment reform. To improve quality, we need to change payment to reward what matters, and to succeed in new payment models, we need to focus on quality improvement. Yesterday, Patrick talked about several models from the CMS Innovation Center that highlighted this link, including the CPC Plus initiative, our next generation of a primary care medical home model starting in January. And this, as Patrick said, is a new model that we're excited about that will get primary care clinicians off the fee-for-service treadmill. He also talked about our ACO models and programs, where we've seen tremendous growth occurring across the country and driving care coordination. So the number of AAPMs, Advanced Alternative Payment Models, is growing and will help us reach the goal of 90% participation in QPP, and we reiterate our request to you to help us reach that goal. This link between quality improvement and payment reform is where the work of my group at the Innovation Center lives and connects to the work that you all do. We run learning systems within these Innovation Center models that help participants succeed through collaboration, innovation, and performance improvement. Another important point Patrick raised yesterday is how important it is to align public and private sectors in these efforts. CMS has done this in several ways through Innovation Center models like CPC Plus, the Oncology Care Model, and the State Innovation Model. But one of our most exciting initiatives has been the Healthcare Payment Learning and Action Network. This is a public-private partnership that we will be very fortunate to hear more about from Dr. Mark McClellan, one of the LAN's Guiding Committee co-chairs. We'll actually hear from 3 administrators this morning. That must be a record. Finally, yesterday we were so fortunate to hear Dr. Tom Frieden from CDC talk about the link between public health and healthcare. I was particularly struck by 2 quotes from Dr. Frieden. The first was, "We make it way too hard for providers to know how they are doing." And the second was a question he posed: what if we restructured the healthcare system so that the primary outcome would be health? I think these 2 quotes are related. Providers and patients want health, so we need to continue driving towards health in measurement, payment, data, quality improvement, and more. Dr. Frieden mentioned some of the exciting initiatives that take on this connection between public health and healthcare, like the Diabetes Prevention Program, Million Hearts, and Accountable Health Communities. Initiatives like these and other efforts from CDC, CMS, and from you all in the healthcare community will help close those knowledge and implementation gaps that Dr. Frieden mentioned, and will help get us to better health, smarter spending, better care, smarter spending, and healthier people. So with that, I'd like to introduce my colleague, Dr. Kate Goodrich, who is the director of CMS's Center for Clinical Standards and Quality, and I'm very pleased to say CMS's new Chief Medical Officer.
Good morning, everybody. I think we have fulfilled our hope that this conference would be every bit as engaging, exciting, and yes, fun as it was last year. I've had a great deal of fun these last couple of days and looking forward to closing out today. So our next agenda item is a fireside chat with Jean Moody Williams and our acting administrator, Andy Slavitt. I think Jean needs no introduction to this audience. You've seen her several times already during this conference, but I am incredibly thrilled to introduce you to my boss, acting administrator Andy Slavitt. Andy has been, as you all know, a relentless champion for health system transformation, quality improvement, transparency, and keeping patients and families at the very center of our work. I want you to know a couple of things about Andy. Anytime that we are briefing him on a policy or a program, I can pretty much count on him to ask at least two questions. Number one is, tell me how this work is going to impact patients and families. Tell me exactly what they're going to feel. And number two, tell me how what you're doing is going to make it easier for the clinician or the provider to be able to do their job to take care of patients and provide the highest quality of care. And I will tell you, as a physician and as a caregiver for a Medicare beneficiary, it has been extremely gratifying to have a boss who looks at our work through those lenses and makes us really put ourselves in the people's shoes that we are impacting at CMS. The other thing I want you to know is that Andy has also pushed us at CMS to approach our work in new and much more efficient ways. I think based upon his experience at coming in at the healthcare.gov rescue, he recognized that we really needed to get out of our silos at CMS and have accountability for really all of our work, but certainly for major projects like the Quality Payment Program across the agency in an integrated fashion. He also really, really strongly encouraged us to get out of our offices, to get out of the building in Baltimore, and actually go out into the field to see what's happening with healthcare at the front lines, at the point of care. And having been at the helm of the QPP work, we really have been trying to work in that fashion. I can tell you that it started a very needed and very significant and welcome culture change within CMS. And on a personal note, I know that I speak for all of us here when I say that I'm going to miss you, Andy. I know we're all going to miss you. I'm going to miss your clear-eyed vision for how we make care better for patients, how we make systems and policies better for clinicians and for other providers, and for how we at CMS can do our job better. And I know I speak for all of us when I say I think one of the things I'll miss most of all is your tweets. As a private citizen, of course, you can tweet with wild abandon, I feel sure. It has really been my privilege to work with you over the last couple of years. And on behalf of everybody in this room, I want to thank you for your public service and for everything that you've done for patients and families in this country. So I give you Andy Slavitt and Jean Moody Williams.
Everyone. Thank you all for, oh gosh, the house is full. Thank you all for coming back on this last day. You've stuck in here with us, and we've gotten a lot of good comments. We're really grateful to have you, Andy, come and join us on this last day. We've had just tremendous amount of learning and networking going on. And I imagine this is probably a period of reflection for you as your time winds down. You know, I've really admired, you've spent a lot of time going back and forth from DC to Minnesota to all across the country. And so I'd like to ask you a few rapid fire questions before we get into the really deep questions, but really important questions. Okay. So you've had a number of, you've been flying all over, you've logged a number of flight hours and those kinds of things. So really important, on your flights, peanuts or pretzels?
I think pretzels.
Pretzels.
Yeah.
Now, how about the Maryland crab cake? You know, we're in the home of the Maryland crab cake or Minnesota cheese curds.
I'll go crab cake.
Crab, yeah. Hey, everybody. Now, Vikings, Ravens, or Redskins?
Bears.
All right, last one. House of Cards, Scandal, CMS.
House of Cards and Scandal probably don't hold a candle to our life, do they, Gene? I'd say House of Cards.
Okay, all right, great, thanks. Now that we got the important questions out the way, and really as you reflect back to when you first came to CMS, you faced a number of challenges, and you also challenged us to do a number of things. And as you reflect back, what were some of those challenges, and what can you say about them now as you look back?
Yeah, I think the place that, and Kate did a service to this answer a little bit already, which is culture. The thing I learned right away coming in at meeting people was so smart, so generous, so gracious, so talented, and so I felt like, if anything, I sized up really quickly. My job was to just give people permission to be creative, to listen, to go outside the lines, to interact, to have a culture where we could be transparent, including when we made mistakes, and just find ways for the team to be able to thrive, because they're so good at what they did, and I think people were so kind to let me participate in that. So that was, with that, I think it tended to almost always lead to better results.
But you were coming from a lot of private sector work into this government machine. And so what were the observations that you made about how we did our work and things that we needed to change?
Well, I think, my lens was not so much what needed to change, but I needed to adapt to that environment. I needed to understand. I didn't want to bring a private sector environment. I did think that, as in almost any environment, not whether it's public or private sector, we tend to get siloed and rigid, because as we get tasks on our plate, we tend to focus on the most efficient ways to do them. It's only natural. I think that had happened over probably a period of years at CMS. And what was fascinating is the talent in CMS was in so many different places, in the regions, in the quality organization, in the Medicare organization, in CMMI, and people just didn't seem to have as many opportunities to interact with one another where they had the time to get to the best results. So some of it was just facilitating those very simple things, and I think the team itself drove to just, I think, great results from there.
So we have a really diverse audience here, those that provide care. We have patients and families, quality improvement entities and networks across the country. One of the things that Kate mentioned is really your passion to reducing the burden and breaking down barriers so that physicians and other clinicians can really do what it is they want to do, and that's caring for the patients that they serve. So that hasn't necessarily been an easy job, and I think there's a lot of work to be done. What would you say about some of the things that you've observed that we need to be working on, and how can we, in this audience, really move that ball forward?
Yeah, so, first of all of us have our own experiences in the healthcare system, and we tend to think of them kind of very personally. We tend to think of them as they tend to overwhelm us if they're going on in our lives. I know that I've had some of those with my family fairly recently. And then we get into kind of this work environment, and we kind of wonder how to make it better as a whole, and sometimes it can feel really overwhelming. And so the voices to CMS of this community you talked about, of this network, patients and families, and people who touch and provide the technical assistance network to the clinical community, is vital. It's a part of everything that we do. And I think if you take the example of the quality payment program, there's only so much that we as an agency were able to accomplish. What we really need to have happen is that everyone in the field, everyone in the communities, really takes to heart this very simple, straightforward goal that every physician in America, whether they've ever had an experience getting paid for quality, whether they've ever had a lot of resources in their practice, all of whom should have an opportunity to participate and succeed in these programs, because it's not truly going to be successful unless every American has access to high quality care. I already know that a number of us have access to high quality care. That's not the problem. The problem is, can we get everybody to have access to that high quality care? And that's going to take this group.
So, and along those lines of making sure that we use, for example, technology to open up access and to be a tool in how we do our work. That's been an area that we've had to do a lot of work on, using EHRs or moving that ball forward, using making data available for apps. What can you tell us more as we think about the vision forward in this area of technology?
Sure. If somehow EHRs became a industry before they actually developed products and services and created satisfied customers, and forget how that happened. We can all trace our own kind of sense of that. But the promise of technology, we all know, it's to connect us. It's to give us information we needed. It's to make things simpler. It's to take something that took us 30 minutes and allow us to do it in 15. Technology does that in all these parts of our lives. We don't have that in healthcare. When I hear a physician say, "Let me talk to you about technology," when a physician says to you, "I want to talk to you about technology," do you expect a good thing to come next or a not good thing to come next? That has to change. And we started that process out almost a year ago in January by calling it out publicly and saying we've lost the hearts and minds of physicians because we have tethered them to technology. And by the way, that technology doesn't provide, it's not geared around them. They're supposed to gear their lives and their practice around the technology, and they deeply resent it. Worse than the time loss is that sense of having lost them and having lost their connection point. So the question is, what can we do about it? I think there's a couple things. One is we really went hard and asked the tough questions about how we can lighten the load of regulation and box checking. That's a huge step, but only a down payment. Secondly, the technology companies have to be able to compete to please physicians. So they're going to be required to have open APIs, and that means the desktop lock that any physician experiences today is going to go away. Because if the EHR vendor's not pleasing them, someone else is going to come in and do that. Which means we've got to get the third thing to happen, which I'm going to point to, which is what I think we all talk about as interoperability. Physicians talk about it much more simply. Can I find out what happened to my patient when I gave her a referral? And I'm going to be very clear, there's no technology barrier to interoperability. There's a business model barrier. And I've used whatever amount of effort people will spend listening to me to try to call that out and to say that is shameful. We've spent $30 billion to create dozens of data silos. But that's no good. That's no good. And so we have to call it out because they can interoperate. And they have 10 different excuses, and as soon as you address them, there's 10 more. Oh, it's a privacy concern. BS, it's not a privacy concern. Oh, it's an intellectual property concern. No, it's not. All of these things. And so physicians are not going to be happy until we can solve all three of those problems. I know that we can. Will we?
Well, I thank you for that, and also thank you for your accessibility, because really, as he speaks, he's speaking from what he's heard. When he tweets, people respond, and he responds back and expects on an individual basis that someone will contact them. Ask me how I know this. And so it's been really good engaging, you've talked about the quality payment. And we've talked about the quality payment program a lot at this conference. Is there anything else that we should be aware of? Because you were one of the chief architects of how we implemented this program.
So I think starting off on the right theme, which is that it's a very diverse healthcare community. A 2-physician practice in Arkansas is a lot different than Mass General, and we can't try to shove a one-size-fits-all program down everybody's throat, whether that's the pace, whether that's the amount of measures, whether that's how they experience it, whether it's how they interact. So that's great. That's a fine place to start. But I would urge all of us to appreciate that there is so much more that could go wrong than can go right. Because why? Because physicians, they don't want to be measured. Well, who wants to be measured? I mean, if I told you the government was going to put in place a system to measure you, you'd say, hey, wait a minute, how can they do that? So we are starting off with something that people are prone not to like. What we have to do is turn it around, turn the table so it's not us measuring them, but it's a quality improvement program for them to improve the care they deliver. They should be able to customize it to their needs, to their practices. It should feel very accessible, and they should know where they stand. And we should do this with a great deal of humility and a great deal of listening. If the program looks the same a year from now as it does today, we will have failed. We will have failed. That means we need to hear from everybody in the field who says, hey, this thing you thought was a great idea, it is, if you do it this way. It's not if you do it that way. If we don't hear those insights, we'll get it wrong. We'll get it wrong because there is no possible way here in Baltimore or Washington or in any central place we could know what goes on in community and what describes good care in every practice. So we have to keep chasing it. We have to continue to be humble about it. We have to continue to engage people on it. It needs to feel like their program. And part of the way to do that is to make people understand that we in this country own the Medicare program. Just to put it on the Medicare program, we own it. This is a program that 50 years ago took a country where 1/3 of our seniors lived in poverty. 1/3 of our seniors lived in poverty before Medicare was implemented. To today, where it's fewer than 1 in 10. And it's because we give people the security and we give people access to the health and the care that they need. And the clinicians need to feel a part of that program, like they own it, not like they're victims in it. And that is a mindset change. That's a cultural change as much as it is anything else. And so when we implement a program like this, it's a chance for us to say, here's what we believe. It's not a chance for us to just say, this is the right quality metric or that's the right quality metric. It's a chance for us to demonstrate how much we value the care they deliver to our beneficiaries. Every time I see a physician who takes care of Medicare patients, or especially Medicaid patients, the first, if maybe the only thing I say is thank you. Thank you for providing good care. Thank you for caring. We have to say that.
You mentioned Medicaid, and we have quite a number in the audience that care and administer the programs for Medicaid. It's often said that we don't coordinate enough or bring those all of our programs together. What are your thoughts on that?
Yeah, maybe I'll use that to just talk about the thing I think is most important, which is health equity. Because I'll tell you, like, someone in my immediate family, I won't mention who for HIPAA reasons and so forth, went to a physician's office, and the physician left the room, and they were nervous, and they saw their chart, and they went and looked up on the chart, and there was a gold star on the chart, and she said, oh, I got a gold star. Or he said, she said, I'm not going to say who. It's a gold star. And looked and it said, related to CMS administrator. And you know what? Every patient in this country deserves that gold star. Because if think about it, we know how to deliver great care. That's not the problem. If we could just make sure that the people that were not getting access to the best care experiences could get access to what the rest of us are lucky enough to get, we would be great. Think about all the problems we would solve. We would solve the cost problem. We would solve the quality problem. We would solve the happiness problem. We'd solve the financial security. We'd be in good shape. We'd be in really good shape. So getting serious about that means that for us, we have to take a leadership role, and that it means for us in everything we do, we shouldn't just be asking about what's the average. We should be asking people about what's the most challenging. What about the people who you're most concerned about, who you're not sure you can deliver the best care to? How do we wrap our relationship skills around that? And by we, I'm talking about in the community. How do we wrap our best thinking around that? How do we invest in that? How do you help us invest in that? Because I really believe that's going to be the key. Sorry.
So one last question. As you look back and you begin to move on and you're talking to those in the field about your days at CMS, and they say, you know, Andy, what was your legacy? How would you answer that question?
You know, I just think, I mean, look, we have in the room, and you're going to hear from them, a couple of people who sat in this chair before I did, and next year you're going to have someone else who's sitting in this chair. And I really just hope I passed the baton in the relay race in a way that created some improvement, made us better, and allowed for the next set of folks to make us better. I will tell you, I will leave this place with a high amount of confidence for the reason that Don Berwick actually told me early on, which is the leadership of the career staff at CMS is the most passionate and committed and smart and focused set of people in healthcare. And it has to be that way because we're so dependent on CMS. And I've really found that to be true. So, you know, as a leader that comes into an organization like that, you know, again, for me, it was really just about focusing on the culture, so that people felt like they could do their absolute best, and so that others would want to come in and work there. And hopefully, it'll continue to get better and better, and I think it will.
Well, it's certainly been my honor to serve under you. I've learned a lot, and I've had the opportunity to do a lot. And on behalf of everyone, we thank you.
Thank you.
So Gene, you know how we do emergent strategy, like things that weren't planned that we do kind of in the moment?
Yeah.
Well, to our knowledge, this is the first time 3 administrators have ever been at the quality conference.
Right.
And we would like to get a photo of the 3 of them right here in front of the stage. And I understand we got a cameraman. Thank you. Mark said, we have to send us a copy. Beautiful. Back to you, Gene.
That is awesome. I actually had the opportunity to work for all 3 of them, so it's been great. How lucky am I? So just a couple of reflections as I move from the stage. First, just to, again, thank all of you for all that you've done to make this conference a success. And, you know, just looking back on day 1, and here it is time now for us to go home. The time went by really fast. And as we left the first part of day 1, I met people in the hall, and they said, you know, that opening session was really good. I really enjoyed it. But I was so disappointed. I'm like, well, how could it be so good and you're so disappointed? What happened? And they said, well, you know, you've been coming to this conference now for 8 years. You've been showing us your kids. You didn't show us your kids. And I said, well, but it was so many people, I didn't think I should do it. They said, well, we want to see them. We helped raise those kids. So here they are. Your kids are grown. It's my 3 daughters. My oldest daughter, who's now going on her 4th year of marriage, is still traveling the globe, no grandchildren. My middle daughter just got engaged in June, so a wedding to come. And this is my husband and I on celebrating our 35th wedding anniversary. And you can tell I'm thinking about the quality payment program in this picture. So thank you for asking. So we really, as I look back over the conference, just can't say much about the wonderful sessions that we've had, the evidence-based posters, many of the announcements that we've had about safety and transparency, and yes, and I don't even know if we announced this, but the release of the inpatient rehabilitation and the long-term hospital compare sites were released from CMS. So nearly every setting we have information that consumers can use as they're making choices. We had some murals that were developed by the patients and the families that were in this room. This happened to be with the ESRD session, and I spent some time with them, I think on Tuesday night it was, and I was looking at the mural, and there was one section of the mural that really stuck out to me. I'm going to show you this little corner there. And I happened to mention it when I was in their section, and it says, it's a dialysis chair, and it says, I've got to sit here for how long? People need to experience it for themselves. And I said to them, I said, you know, that really just stuck out to me, and maybe we ought to have rotations of people coming through and just sitting in that chair for 3 hours or more. And they said, well, you can't just do that. You have to have them sit in the chair with a blood pressure cuff on their arm, with a needle in their arm, with a saline bag in their lap, and not be able to move because their life depends on it. Now that's a thought. And so I can't help but again thank all the patients and families that have come and assembled here to make this conference the success that it is. Could you just give them a hand? Thank you. And my last slide, I think, is a perfect way to introduce our next speaker, because I actually was hired in under Dr. Mark McClellan, and he brought me in to set up the Medicaid Quality Improvement Program. And he's such a great advocate for quality and value. And he established, and CMS at the time, we had the Medicare payment component, we had the Medicaid and CHIP payment component, and then we had this Office of Quality over here. And the two weren't very well integrated. So he set up this quality council, and he made it a requirement that people had to come. And some came kicking and screaming, but they came. And we began to work together. And I just want you to know that we continue. We now have our quality council that continues on. And we have a group, affinity groups now that come together because they want to. And they develop great products. There are about 13 of them that cover every topic you can imagine in quality. So when we talk about legacy, know that we're still doing that good work. Dr. McClellan is the Robert J. Margolis Professor of Business, Medicine, and Health Policy and Director at the Duke Margolis Center for Health Policy at Duke University in Washington, D.C. And this center supports and conducts research, evaluation, implementation of educational activities to improve health policy and health care. He's a doctor and an economist, and his work has addressed a wide variety of strategies. And I really don't think I have to tell you this because his work impacts all of us. And he is right now still working in the area and as co-chair in the guiding committee for the Healthcare Payment Learning and Action Network, and has many, many other roles that maybe you'll learn about as he comes. So could you please help me in welcoming Dr. Mark McClellan?
Jean, thanks very much for that introduction, and to all of you here, it's a real pleasure to be with you this morning, part of, I guess, the parade of administrators that is now an element of the CMS Quality Conference. The reason I am so much of a privilege to be here is to see the trajectory that we're on. As Jean mentioned, we started some quality programs when I was at CMS. I remember my first remarks is after I'd been confirmed as CMS administrator was a talk to the CMS staff about how CMS was the nation's largest public health agency. And that got picked up a bit by the press with people outside the agency asking about, well, does he really know? He's not at FDA anymore. This is no longer under the public health statute. It's Social Security. But for the staff, there was a strong awareness then that has clearly increased over time that what CMS does matters for health. And you've seen it reflected in the events presented here, the activities and initiatives presented here over the last couple of days on patient safety and life saves, on a huge range of quality improvement initiatives, on population health. I want to come back to that in my remarks, on new steps towards making quality information available to support good decisions by patients and their clinicians. But I do want to give a special thanks as well to the CMS staff, which really is incredibly committed, working with limited resources to do what's best for the country. And as this journey continues, I know all of you here from CMS are going to continue to make that kind of difference. It also is important to emphasize, though, that healthcare reform doesn't take place in Baltimore or even in Washington. They're very important health policy decisions that influence where our healthcare system can go. But real healthcare reform takes place, as Andy emphasized this morning, between patients and their physicians, as people are getting care in doctors' offices, between patients and their specialty providers, skilled nursing providers, and increasingly in patients' homes and in the communities in which they live, as healthcare continues to move towards more personalized and prevention-oriented approaches to care. And we still have a good ways to go on that journey, and that's what I want to talk about this morning. So despite all of the progress that we've made, and maybe because of all the progress that we've made in quality of care and improving outcomes in the medical system for patients, we are continuing to see rising healthcare costs. Despite a slowdown in the last few years, as you can see from this chart, which shows GDP on the vertical axis and a long-term outlook for the federal budget over time on the horizontal axis, the big story of rising healthcare, of rising spending in the U.S. Is not Social Security. That's going up a bit with the retirement of the baby boom and our demographic shift. It's not defense. It's not national security. It's really not everything else that the federal government does. It's the healthcare program. So Medicare, Medicaid, the subsidies for insurance coverage, all the costs associated with that have risen from about 1% of GDP in the 70s, 5% or so today, and on track for being a lot higher. And the reason this matters is because it shows that we still have more work to do to make care both affordable and available to people who need it the most. Andy talked about the challenges of health tree are large. This is from a study by Raj Shetty, some of my former colleagues at Stanford, showing the big differences in life expectancy, and this is reflected in many other diseases. And these differences are increasing with almost no improvements over the last decade and a half in outcomes for patients, people at the lower end of the income distribution, substantially higher at the high end of the income distribution. And notably, as Angus Deaton and Ann Case reported just recently, actual increases in mortality rates for some segments of our population, particularly low to middle income whites and black males in the United States, which is really unprecedented. And that is despite all of the progress that we're trying to make in healthcare and all the progress that we have made in healthcare. So this is really, I think, a motivation and a call for building on all of the tremendous progress that has happened through efforts like yours around the country in recent years. We need to do more, despite all that we've done so far, to really link up the things that can change the way that healthcare is delivered to things that make the most difference in the lives of patients. There are a lot of Americans today who, despite all of this progress that we've been highlighting, are still dissatisfied about about their health status and about what healthcare can do for them. I think the good news is there still are lots of opportunities to do more. And that's where I think financing really matters. It really is not about, these payment reforms are not about incentivizing physicians or other clinicians to do the right thing, or or incentivizing patients. It's really about alignment. It's about making sure that the resources, all those huge and growing resources that we're spending on healthcare, are aligned with what really matters for improving health of patients and people in the population. So this is a transition to talking about alternative payment models, which the Healthcare Payment Learning and Action Network is all about, and which I know you've had lots of discussions about over the past 2 days, let alone built into the work that you are doing. The main reason I think these payment models are so important is because of alignment. One of my first meetings at CMS was with the heads of a number of physician group practices around the country that were trying to do the things on this list. Move care out of the hospital, even out of the doctor's office, into more home-based, less costly settings, setting up remote monitoring methods, and trying to answer their patients' emails rather than having them come into the office, moving towards team-based approaches of care that relied not just on nurse practitioners practicing at the top of their skill set, but community health workers, social workers, people who could connect with patients that were having trouble adhering to their medications or addressing the risk factors for their conditions, IT systems like Andy was talking about earlier, and getting out of the traditional mode of thinking about healthcare as just something that happens in a traditional medical setting. And they pointed out all these things they were doing, and that these were actually leading to improvements in measurable, important aspects of population health, but then they also point out that Medicare didn't pay for any of them. In fact, to the extent that these activities actually worked, they tended to get less revenues from Medicare under fee-for-service payment, and it made these models just not sustainable from a business standpoint. And that's what I mean by alignment. We started some early programs then, like the forerunner to the Medicare ACO program, some of those early steps that Jean was describing on trying to pay for better care, and that's really grown over the years. The Healthcare Payment Learning and Action Network, which I co-chair the guiding committee for, along with Mark Smith, who many of you know, is a public-private collaboration intended to help advance the difficult work of moving to payments that are aligned with what really matters for patients and for population health. This is an effort, if you're not familiar with it already, that is intended to highlight new ways of delivering care in alternative payment models, and especially to promote the kinds of steps that have been challenging in this move towards new ways of paying for care that help doctors, patients, and other clinicians deliver the best care at the lowest cost. I want to talk about a few of the activities that the LAN is undertaking through partnerships. So this is an effort that has support from CMS, but that is made up mainly of a range of private sector entities, state Medicaid leaders, state health leaders, private health plans, a wide range of healthcare providers, employers, many patient and consumer groups. All of them are represented on that guiding committee that you heard about earlier. And it is a collaboration that, among other things, is trying to help get a clear understanding of what kind of progress we are making and how we can accelerate it on payment reform. One of the LAN's early activities was developing an alternative payment model framework. How many of you have heard of this category 1 through 4 framework? It's also based on work that CMS has done, so a lot of hands going up. Basically, the emphasis is on on moving from Category 1, just fee-for-service, through Category 2, which is now pretty widely used in Medicare and increasingly in private health insurance plans, where they're fee-for-service payments that may be up or down adjusted based on some measures of quality. Historically, unfortunately, too many of those have been kind of check-the-box things like Andy was talking about earlier. But the real emphasis is on these Category 3 and Category 4 models that are more directly about aligning payments with what matters for patients. And the Category 3, I think you can view as kind of a step that's still largely fee-for-service based, a fee-for-service infrastructure, but maybe a separate component related to patient results. And then Category 4 is moving even further away from patient results, from fee-for-service towards patient results. I think of these models as really falling into two main categories, many that are episode-based, so they're not covering all aspects of care, but they are covering aspects of care from a patient standpoint. So primary care, medical home that takes a more patient-focused approach to primary care services, many of the episode payments that CMS is implementing, but also not just for acute illnesses or major procedures in hospitals, also for chronic disease episodes, such as the oncology care model. And then there are more population-based or full person-based approaches, not just ACOs, and a good example of a Category 3 ACO is the Medicare Shared Savings Program, the physician group practice pilot that went before it, still largely fee-for-service based payments, but a second track of payments, which in many of these payment models is increasing over time, that's based on overall cost of care for a population and overall results for that population. The more that payment moves into that Category 4 person-level approach, the more flexibility healthcare providers have in targeting all of those kinds of additional resources and approaches that were not paid for well under fee-for-service to the patients who need them the most. But going along with that is some accountability, some recognition that we are spending a lot on healthcare, and it probably isn't the best path forward to provide lots of access to telemedicine or online services to every single patient. We could if we had unlimited resources, perhaps, but with limited resources, we have to be a bit more judicious. So that's the accountability that goes along with these models, and why it's very challenging to target which patients would benefit the most from particular interventions, and to keep in mind not just the importance of improving quality, but the importance of improving quality while being accountable and understanding implications for overall resource use. The LAN has now developed a wide range of support tools and resources to help with this kind of transition to new payment models, not just that APM framework that I mentioned, but some papers describing best practices and ways to align efforts across multiple payers to support better care and implement these new payment models effectively. And recently, the LAN reported on the first ever public-private effort to assess where we are nationally in terms of implementing these kinds of significant payment reforms and moving towards a healthcare system that is more about alignment of resources with what really matters for patient health and for population health outcomes. This survey reported in October comprised data covering 44% of Americans from 40 major health plans like Anthem, United, and others, reflected collaboration with AHIP, America's Health Insurance Plans, the Blue Cross Blue Shield Association, states as well. We hope to build on this effort going forward, but what we found in this effort was not only were a lot of private entities and states willing to work along with CMS to track where we are, but that we are making some significant progress in payment reforms with, as you've probably heard, 30% of Medicare payments now in systems, mainly Category 3 payments that have at least a component tied to results and tied at the patient or episode level of care, but a growing number of payments and a growing use of payments in these same models in commercial plans, and especially Medicare Advantage plans, and even Medicaid plans, where many of these models include links to non-medical services that often impact health outcomes for lower income populations. So we see 28% overall of healthcare dollars in these Category 3 and Category 4 models in point in time around mid-2016, and an upward trajectory in where these payments are going. So with this foundation, the land is now turning towards a greater emphasis on action collaboratives, with so many programs being implemented and with them starting to show an impact on both health outcomes and costs. It's time to really roll up sleeves and find ways to implement these models more effectively together. We're looking for ahead to finding ways to help make sure that these payment reforms really do support those frontline providers, like Andy emphasized this morning. With the implementation of MACRA, we expect to see a lot of further steps around alternative payment model opportunities for physicians, including physicians in different areas of specialized care and small practices who may not be participating in some of these models as extensively as they will in the future. We're looking for ways to increase drug, behavioral, and community-based services in these payment models, and very importantly, trying to identify ways in which these models can be most effectively implemented across the public and private sectors. With that in mind, I want to spend just a minute or two on the Payment Reform Evidence Hub. This is a collaboration that's an outgrowth of some of the LAN efforts around finding what really works in terms of these new payment models that we're doing at Duke in collaboration with groups like Pacific Business Group on Health and Mike Chernu's group at Harvard that has been a leading evaluator of many payment reforms in the private sector, along with CMS reforms. One of the things that we're doing as part of this effort is tracking what's going on, what we know about payment reforms now. Have to say that most of the actual evidence produced, and CMMI has been remarkably important in getting this evidence out there, but most of the evidence produced from CMMI, from more limited studies done in the private sector and in states, is still in Category 2 type models with growing evaluations of Category 3. And a bit in Category 4, where we hope to see more coming soon. I'd like to encourage everyone here, I know many of you are involved in one way or another in implementing and evaluating payment reforms in conjunction with your quality improvement efforts. We'd love to hear from you. And thanks to the Arnold Foundation, which is supporting this effort, there are a lot of resources available, both informal, curbside consult type approaches, all the way up to more formal research evaluator support for extensive evaluations of payment reforms to help us build the evidence base to work most effectively on implementing new kinds of payment models. And I would emphasize that we have a long way to go, and I want to end on a challenge here. This is a chart showing the performance of the ACOs and the Medicare Shared Savings Program through 2015. The horizontal axis is their overall performance on the set of ACO quality measures, which includes a lot of population-oriented measures for chronic diseases, as well as patient experience with care and avoiding preventable hospitalizations and the like. The vertical axis is that accountability for total spending in the population that I talked about before. So higher is better. That means more savings relative to the expected benchmark. And we've learned, CMS has learned over time about how to make the policies better. But what I want to emphasize here is that there's still work to do, a lot of hard work to do in integrating quality improvement efforts in a way that really adds up to cost savings. Where you want to be in this chart is at the top right-hand side. very high quality scores, performance, health outcome measures for your population, and also savings. This past year, 2015, about 1 in 4 ACOs that participate in the Medicare Shared Savings Program both achieve significant measures of, very high measures of quality and significant reductions in cost trends compared to their benchmarks. As you can see from the chart, on the quality side, this is working. Performance on these quality measures significantly higher overall in the ACOs compared to traditional Medicare. Quality is getting better. But improving quality by itself, I know in a lot of industries, doing quality right means cost savings. It does not automatically mean that in healthcare under our payment systems and policies that we have in place today. It is work to do both. Some organizations are succeeding, many are still struggling. And with that in mind, we are also working on, and partly in collaboration with the LAN, with a public-private effort called the Accountable Care Learning Collaborative. It involves me, former Secretary Mike Levitt, and a number of healthcare organizations around the country to try to link the great work that's taking place through efforts like this, through efforts like Don's Institute for Healthcare Improvement on quality, to what really needs to match up with that to integrate and achieve overall cost savings at the same time. Not surprisingly, the most important thing is leadership, a commitment not only to getting quality right, but to getting costs down from the top of the organization. It's reflected all the way throughout it, but also required are a number of tools that many healthcare organizations really haven't had the capacity or support or ability to implement so far. Longitudinal tracking of patient, not just quality information in say patient registries, but cost impacts. Doing predictive models that can tell you not just which patients are at high risk, but which patients are going to respond most to particular interventions so that you can target them as efficiently as possible. And then linking that to all of the work that's going on around quality improvement and moving towards patient-centered care. This is a big challenge going forward, and to the extent that we don't address it, payment reform is going to slow down. It's going to be difficult to really get the resources that we're spending in healthcare as aligned as they could be with getting the best population outcomes at the lowest cost. Now, we are at a time of transition. It's a real pleasure for me to follow Andy in these remarks because he did such a tremendous job on his leg of the race as CMS administrator. But there are many more legs to come to make progress here. And I do think that payment reform is here to stay. I think as we look forward into 2017 and a new administration, I think you'll see some new flavors of this. I think some more emphasis on state initiatives and on initiatives that try to identify and then support things that are going on in the private sector, building on efforts like the LAN and other multi-payer initiatives that CMS has already implemented, taking those even further. With the implementation of MACRA, more emphasis on payment reform models that work for smaller practices and specialized areas of care. These can complement approaches like ACOs or work in primary care payment reform models. So far, even though drugs are probably the last thing from an economic standpoint that should be paid on a fee-for-service basis, they haven't really been included in a lot of these payment reform models yet. There have been some fits and starts, but I think we're going to get that right. Start getting that right in the next couple of years. A lot of interest from the pharmaceutical industry in models that really support getting more value as forward-thinking leaders in that industry are looking for ways to encourage innovation while still keeping overall costs down. And then perhaps most importantly, even greater emphasis on patients and consumers. Most of these payment reforms so far have been about things like shared savings with providers for getting better outcomes and lower costs. I think coming ahead with the high deductibles that patients are facing today, with some questions about whether consumer-directed care can really work, I expect to see more opportunities, especially for patients with chronic diseases, to share in the savings as well as have more control over their participation with providers who are doing well in terms of the kinds of performance measures that can come out of these episode-based and person-level approaches. So new flavors, but still a continued push because we are just not there yet on getting the best outcomes at the lowest cost for patients. I want to thank you for all the progress that you've made on this challenging journey. Special thanks to the CMS staff who have been here every step of the way and committed to it. I'm looking forward to more progress going forward on all of these efforts to improve care and lower costs for the well-being of the U.S. population. Thank you all very much.
Ladies and gentlemen, please welcome back Dr. Paul McGann, Chief Medical Officer of Quality Improvement Centers for Medicare and Medicaid Services.
Good morning, everyone. Quite the conference, huh? Well, wait till you see what we got for you next. You know, you often hear about any particular speaker that comes on stage. This is a person who needs no introduction. And that is certainly true of Don Berwick, especially for this audience here today. All of you know that he is President Emeritus and Senior Fellow at the Institute for Healthcare Improvement. You know as well that the President named Dr. Berwick Acting Administrator of CMS after the Affordable Care Act became law in 2010. Perhaps some of you were not aware that he conducted a spirited campaign for governor of the state of Massachusetts last year. Dr. Berwick has served several presidents, several countries, not only as trusted advisor on healthcare policy and quality, but also as a leading voice for consumer protection and person and family engagement in both healthcare itself and in delivery system reform. And you're hearing that even in Mark McClellan's comments just now about where the payment system is going in the future. Dr. Berwick has received numerous awards and recognition. My personal favorite is him being appointed by Queen Elizabeth II of England in 2005 as an honorary Knight Commander of the British Empire. For me, though, Dr. Berwick will always be the leader and sage who asks the most effective questions. Everyone in this audience, everyone in our growing community of practice here today, should be aware that the advances in patient safety that Patrick Conway announced yesterday, that all of you in this room caused to happen, in my view, began in earnest in 2011 in a conference room in CMS when Dr. Berwick asked the most effective, simple question I have experienced. After a long discussion of data from dozens and dozens and dozens of individual quality measures that CMS was stewarding, things that many of us have been doing for 10 years, Dr. Berwick asked us as CMS administrator, yes, but is hospital quality and safety improving in the United States? In that moment, the orientation and culture of CMS shifted from a payer of bills and collector of data to shouldering the responsibility and aligning to the moral compass of a public health agency, rooted in a culture of continuous quality improvement and accountability for the health and safety of the people of the United States. Today, we are pleased to welcome Dr. Berwick back among us again. We are grateful to be able to answer his question. Yes, Dr. Berwick, hospital quality and safety are getting better. And Don, this army for quality that you see here today and that you inspired wants you to know that at this conference over the last 2 days, we have recommitted to pushing forward harder and faster until we achieve your vision of safe, reliable, equitable care for every person. Please welcome Dr. Berwick. We have a little plaque here. On the first day of the conference, 400 people in the Army received a plaque like this. And so everyone in the audience knows what it says. But in recognition and with deep appreciation to Don Berwick for diligent work, authentic collaboration with patients, clinicians, and partners, and unprecedented national impact on patient safety in all U.S. hospitals. We'd like you to have this as commemorative for that.
Well, thank you so much, Paul, and it's just such a privilege to be with you. It's very moving to be with you. I fell in love when I became administrator with the people of CMS. It's an incredible community to get to work with and lead, and I remain in your debt for creating the best professional experience I have ever had, bar none. I also want to say a word of congratulations to Dennis Wagner, Paul McGann, and Jean Moody Williams. There are many, many people in CMS to recognize, but these three people were recognized as Federal Employees of the Year, and I couldn't be happier to see their immense contributions celebrated. They rose to the challenge, and they have become national, in fact, international leaders of what we really care about. So thank you. And thank all of you. The achievements of the Partnership for Patients and the other programs that are underway under the rubric of the CMS quality efforts are stirring. They're just extraordinary, far beyond anything I could have imagined. I know that the results are estimates only, and we're going to have to take some notice that there'll be criticism about that, but they are directionally and in magnitude magnificent, and I hope you feel as proud as you should be for what you're accomplishing for the people of this country. When I was asked to be administrator, and agreed, as I left for Washington, I turned to my successor at IHI, Maureen Bisignano, and I said, what should I do? I was scared. And she said, oh, Don, it's really easy. Just mention a patient 5 times a day. And I carried that with me every single moment I was there. That's, of course, the compass for our journey. And to be frank, these are troubling times. I would be naive for me not to acknowledge the level of uncertainty we now have in our country about where we're going to go. I particularly am concerned about the potential weakening of the healthcare safety net in this country, which we must not allow, and backing away from our nation's progress toward healthcare as a human right. And we all will work together on that, I know. When the seas get rough, you better have a compass, and the compass remains exactly what it was through my whole career and through yours. The compass is helping people to live long lives and to reduce suffering. We will be united not by our approaches to that goal, but by the goal itself, by the pursuit we're after. The values unite us, the values that healthcare is a right, that it is wrong to blame the sick for their illness, or the poor for their poverty, or the hopeless for their despair, that it's wrong to use blame as any excuse for withholding care or compassion or hope. As Andy Slavitt said so wonderfully in his remarks, CMS is here to carry that banner forward, and it will be here, it will remain here. The public sector commitment to those values, to me, has to be unwavering, and it will be. That said, you know better than anybody that no one can claim that American healthcare today performs as it should, or as we all need it to. Pursuit of the triple aim is it's a strategic and ethical imperative for the nation, and that doesn't change no matter what the atmosphere or circumstances around us. We also know and are united by science, by the concept that the pursuit of those aims, healthcare as a human right, the triple aim, can have scientific foundations. We know a lot about how to achieve it, and your results, what you're able to book at this meeting, aren't the result of trying harder. They're the results of trying better, trying the right way, using science for the improvement of healthcare delivery. We can manipulate and change payment as much as we want, and should, under the leadership of visionaries like Mark McClellan. But the payment has no effect if its effects are not carried through by scientifically grounded changes in the delivery of care. And that combination, proper payment and proper science brought to the delivery of care, is our shared mission. We know
we know what's wrong, and I want to show you what's wrong just to remind us. This is an example from England. If you want to be confirmed, by the way, don't say anything about being knighted in England. It's not a route to confirmation in my experience. But I do have experience there. So you probably know the story of the Mid-Staffordshire Trust in England. It was a very important, award-winning hospital that went off the rails. It began having high mortality rates, and the lights went on about high mortality rates for 2 or 3 years, and nothing happened. And finally, it became a crisis 4 years into it. It led to a big national report in England called the Francis Report by Robert Francis, 1,700 pages of analysis of what went wrong in this hospital that went off the tracks. And I chaired a commission in England at the request of the government to study what went wrong and what to do about it. There are a lot of lessons in Mid-Staffordshire. I'm going to give you some books to read, by the way. I warn you in this talk, but one of them might be the report that I wrote with my commission on the Mid-Staffordshire. It's called A Promise to Learn. There's a lot of lessons there. I'm not going to go into all of them, but I want to point out one thing just to show you. What happened was alarms rang that mortality rates were rising, and then suddenly the Mid-Staffordshire mortality rates became normal. And when we investigated how and why, the answer was that Mid-Staffordshire changed the way they were coding deaths. They didn't change the care. They manipulated the metric. They played games. Here's another example. In England, there's a target for waiting times in the emergency departments, A&E, and hospitals got heavily criticized, and people got fired if average waiting times went above 4 hours to disposition in the emergency rooms. This is a chart from an analysis of waiting times in the Mid-Staffordshire region. Notice the number of patients that leave the emergency room at 3 hours and 59 minutes. Games are induced. Blame, inspection, incentives alone, not coupled with increasing capacity in the delivery system, leads in the wrong direction. It demoralizes the workforce. It leads to hiding information instead of surfacing, and the opposite of improvement. It leads to running. In a non-scientific environment, when the approach to improvement is only through exhortation, it's only through incentive, it's only through control systems, it feels like this to the workforce. A heavy emphasis on control and energy diverted from, taken from, the real essence of improvement, which is learning, continuous learning. No one can learn in the dark, but darkness descends when fear becomes the major mechanism in the environment. The job is to be smarter than that, to know that we can't accede to the cycle of fear that comes when only exhortation, only carrots and sticks are brought to bear on improvement. You've seen this cycle before. It's written first by Bill Schirkenbach in the 1950s at General Motors, that inspection-oriented improvement leads to fear. It leads to anger at the inspector. Nobody in quality assurance ever gets invited to a party. And it leads to manipulation of the information, just as we saw at Mid-Staffordshire or in the A&E waiting times. And it enters the system and becomes a self-reinforcing cycle because the management responds that way. This is the cycle to end. This is the migration of our understanding, the growth of maturity in approaching improvement and understanding that the way to improve is not through insistence, but through learning. I love the title of the group that Mark and Mark Smith are chairing, the Learning Action Network. I love the concept of that CMS is so invested now in the kind of network learning represented in this room, 2,000 people getting together to learn how to do better. It's wonderful. When you don't do it right, measurement goes wild and becomes, instead of an assistance to the system, a weight upon the system. Accountability becomes the language instead of aspiration. We begin to blame the very people we're helping. And we emphasize standardization way beyond what's useful. Because when you measure, you need standards, and without standards, you're lost. But standards aren't always the answer. What the answer is listening. The consequences for the workforce are dire in an atmosphere of inspection. We know that 50% of the physicians in America today would not recommend to a young person that they become a physician. We've got to change that. And when you listen to Andy Slavitt, as we did this morning, and you hear his compassion, his willingness to understand this, the emotion of the workforce, and how we, and CMS are responsible for building positive relationships as the precondition for effective work, we begin to find a way out of this, this tunnel. The proper distribution, which I showed in my talk here last year, is a balance between systems of control, which are needed. So when the tire goes flat, you fix the tire. But the tire is usually not flat. And most of the time, what you want to do is continually improve your driving. And that learning process, the essence of improvement that's represented in this room, is so much more powerful than an atmosphere of surveillance and blame and insistence that demoralizes people. And reserving energy for invention of all the many wonderful things I got to participate in when I was leading CMS. Top of the list for me was establishing the Center for Medicare and Medicaid Innovation with Patrick Conway's enormous help and the help of your leaders in the room. This nation decided to invest considerably in reinventing care so we can have a system that performs differently. I desperately hope that as we hand the baton to a new administration, that they understand the wisdom and the importance of a nation willing to invest in exploration as the route to new systems, as well as trying to work with the status quo system. When I came to CMS, I set out a framework which I simply want to repeat to you here. I believed in it, I still believe in it, and I was delighted to see the ongoing administrations at CMS embrace it. The framework is of mission, which is our goal as an organization, started by Mark McClellan, and when he conceived of us as a public health agency, is that we're going to try to achieve better care for people, better health for populations, and lower cost. And that combination is achievable, but only if we intend it. That's our mission. And to do that, we have to have a vision of the organization. This is what I tattooed on every one of the employees at CMS the day I arrived. We will be a major force and a trustworthy partner for the continual improvement of health and healthcare for all Americans. And I see every element of this vision in place and active under the stewardship of the terrific people that now lead and work in that organization. A major force. This isn't a time for passivity or reaction. It's a time for direction and investment. A trustworthy partner, because as Andy said, we cannot do it alone. The workforce and organizations that we work with, the patients and families, they are our partners in change, not the objects of our action. For the continual improvement, a job will never be done for health and healthcare. That means partnering with agencies, civil society, and others that care deeply about preventing illness as well as treating it for all Americans, because frankly, where Medicare and Medicaid and CMS go, the rest of the country will follow. And so you are leaders not just of the federal insurance system, you're leaders of the healthcare system of the nation as a whole. But science is going to matter. We won't be able to achieve what we're after unless we helpers act as we wish the helped to act. If we want healthcare to be boundarylessness, we have to tear down the walls between Medicare and Medicaid, between every agency within government, and begin to act like the team we are. We must move agilely and with speed because the taximeter is running on this. People are suffering as we speak. It's going to involve teamwork. Resources will always be limited, and sharing is the best rule for success. Innovation is crucial. Just as we would ask healthcare to change, the methods of CMS have to change, and the voice of the customer has to be present in the room as it is in this room. These were the values that I tried to bring as administrator. They're values I deeply believe in, because if the values are wrong, the strategy won't matter. So change is afoot. There'll be a new administration, a new regime. Some things aren't going to change, though. The social need for the triple aim doesn't change. It is still here. The special vulnerability of disadvantaged and vulnerable populations isn't going to change. The laws of economics and actuarial science aren't going to change. The ethical imperative that we help each other doesn't change. And by the way, that we help the planet, that doesn't change either. nor does the science of improvement. If we want to make things better, we have to use the methods that make things better. And among those methods, what doesn't change is that we will always learn more together than we will separately. And so the value of shared learning that has been carried forward so magnificently in the work under Dennis and Paul and Jean's leadership is the way to go. It's important to identify and reduce waste. You will discover, you already know in the work you do, that so much energy in healthcare goes into things that absolutely do not help people. And as the payment systems migrate, under the guidance of people like Mark, we have to use that new possibility, the possibility of a new payment system, to find and root out activities that don't help anyone, so we can take those energies and devote them to things that do help people. No matter who's in charge, what I just said is still the right plan. And here's the deal, you are stewards of that plan. Nothing happens other than through you and your colleagues. And so the responsibility remains with you no matter what happens in Washington. How can you keep your compass? Remember Maureen's advice. Mention a patient 5 times a day. Keep the patient and the loved one first. You've done that. You're proof of concept of this. Because the achievements that Paul and Dennis have shown me are testimony to the level of commitment that you've had. 21% reduction in overall harm in this 5-year period. That's all harm, not just an attempt to classify preventable harm. 3 million harms avoided compared to 2010 when we started. $28 billion in savings. Maybe as much as 125,000 lives saved. Boy, you ought to just come to your feet and take a bow. But now where next? And let me take the last few minutes to talk about the next steps, because we're not done, we'll never be done. You have a challenge before you now, the 2012 challenge, if I understand it, 20% reduction in all-cause harm. We're not going to parse anymore preventable or not preventable. Harm is harm, and it is all to be stopped. That's maturation, by the way. And a 12% reduction in all-cause 30-day readmissions for all payers. Magnificent goals, hard goals, the right goals, and you need to go for it now. Unfortunately, the wages of success are that more is expected of you. If we do that, we'll achieve unprecedented levels of experience for the people of this nation. And I think it's extraordinary. So let me talk a bit about how. It's sort of the next bar, and then we can celebrate and go home. There was a survey done by ACHE in February which asked top leaders to rank the problems in front of them, and across the board, finance was problem number 1. Quality and safety was problem number 2. I didn't learn second, do no harm. I learned first, do no harm. And one of the underlying theories I've got, and I think it would apply to our work, it's a deep confidence that in a century of progress in understanding human enterprise now, scientifically, what we've learned is that the best route to financial success is the improvement of the experience you're helping, of the person you're helping. Quality is the proper tool for the achievement of financial success. And what we can see in the but we still have a leadership which, for totally understandable reasons, isn't really convinced of that. They think they have this finance problem, and when they're done with that, or maybe after that, or maybe down the hall, we'll work on the quality problem. And there is a big step to take in this nation, and I believe in our healthcare system, to understand that the tool for change is improvement itself. So what's happened? We made progress, but we have to keep going. And I would argue quality and safety need to move back up to the top of the list, not instead of finance, but to solve the finance problem. And if we can, as a community, in the next few years, migrate toward that understanding, we will, by the way, be joining other mature industries on the planet. But we'll actually have a way to save the money without hurting people. And that agenda, to save the money without hurting a hair on anyone's head, to me is essential to the mission. There is evidence now, proof of concept in the level of success we can see in pockets on almost anything we set our mind to improve. We can find an example of improvement at an unprecedented level. The problem now is to make it true for everyone, everywhere. And to do that, the paradigms will have to change. Now, I'm stealing the next few slides from my colleague at IHI, now the CEO there now, Derek Feely. Derek has put together an agenda for the new safety. That's a lingo you're going to hear a lot about. It came from the National Patient Safety Foundation and others who were saying, well, sort of what's the next level? It's a maturation thing. I'm a pediatrician, so I always believe in maturation. Here's a couple of ideas. Some of these are sort of zen, but we'll work together this year and over the years ahead to understand what this means. The first is there's a shift of frame, I guess, from stopping things from going wrong to making things go right. That is, a mature approach to safety is actually a full embrace of a concept of pervasive reliability, that we can produce reliability at any level we wish, in any process we wish. It's not waiting for a defect and then preventing the defect. It's understanding what reliability looks like pervasively in a system. The second suggestion is key, which is to move from reactivity to proactivity. We are used to saying something went wrong, let's fix it. This is a change in frame to thinking about what might go wrong and how to intercept it. Reactive to proactive. The third is to deal with the entire system, not parts of the system. I go to hospitals who say, we're overwhelmed with work, too many things on our list, too many projects. And that's not the right way to think. The project is to change the nature of the organization itself so that safety, quality, reliability becomes central to the everyday work of the place instead of just a list of tasks. If you're thinking of quality and the pursuit of safety as a list of projects, of course you'll get exhausted. If you think of it as a transformative view of what the nature of an organization is, you can have a theory, science. The master of this is, of course, Carl Weick, a professor from the University of Michigan, who has been the leader, the founder of the field of high reliability organizations. And Weick and his colleagues have shown us what it's like to be a transformed place where safety and quality is not a series of projects, it's in the nature of the place. What Weick and Sutcliffe digest in their unbelievable book, Managing the Unexpected, are 5 properties that pervade organizations that have levels of safety, reliability, and experience that aren't achievable in other kinds of organizations. The first is the assumption of failure, the concept awareness, the constant awareness that failure is everywhere around us and can enter the system at any point. Preoccupation with failure, they call it. The assumption that something will go wrong, not that everything will go right. The second is a reluctance to simplify. The systems you're working in are highly complex systems. And beginning to understand systems for real, what they are actually like, and their nonlinear properties in the feedback loops, it's the alternative to simplification that makes us feel good but's wrong. Hindsight bias, when we say, oh, the last thing that happens, the cause, the nurse screwed up. No, the network, the system, set up the circumstances for failure. The third is sensitivity to operations. Weick and Sutcliffe say, on an aircraft carrier, which are ultra safe compared to the dangers, if there's a wrench left on the flight deck, the admiral will know. It's a flat organization where knowledge pervades the organization and everyone knows what's happening at the Gemba, on the shop floor all the time. The fourth is a commitment to resilience, and that's trusting the workforce. It's enabling a workforce which has the duty, the right, the privilege, the pride to act locally when local action is needed with all the degrees of freedom they need to do that. It's the opposite of command and control. And finally, deference to expertise. This is the property they write about in which a problem moves around until it finds the person who has the solution, no matter what the rank is. By the way, I've got 6 books for you to read. I want to emphasize, we are scientists now, you are. And I want to just quickly run through the list because it's only 1 book every 2 months. I'll be back next year and we'll have a quiz. You want to understand what we mean by systems? Read The Fifth Discipline by Peter Senge, 20 years old now, and it's still a great book that helps you understand the nature of systems. You want to understand how to do even more effective cycles of improvement? Read The Improvement Guide by Langley, Nolan, and Nolan. You want to understand why it's hard, what's going on within organizations, where the psychology of change is in your way? Read Chris Argyrs' book, Overcoming Organizational Defenses. You want to understand high reliability at the varsity level? Read the book I mentioned, Weick and Sutcliffe's Managing the Unexpected. The best book, the one to start with, this is the one for your bedside, is called The Design of Everyday Things. It's about human factors design. It's a brilliant, lovely book explaining how it's the design of where we work that determines how we work. And Don Norman's book is well worth reading. And then finally, if you want to understand error, read the Bible. It's Jim Reason's book, Human Error, still the best thing ever written and the first thing ever written about human error. The reason I'm belaboring this with you is I do want you to read the books, but more than that, I want us to embrace the science because the science works. We have to give up blame. There's no way that it's going to be done in a culture of blame and finger pointing. This has to do with humility, trust, and complete transparency. And we have to do it with patients and others who work with us. Do I have time to show a quick video? Am I okay? Too far? I want to show you something. In Sweden, I've come to, where I work a lot, I've come to know a hospital in Jönköping. Jönköping, Sweden is a county. Sweden is a single payer system that funds at the county level. In this hospital, a patient arrived named Christian Farman. Christian had kidney failure, and he was an engineer, and he asked the hospital if he could do his own hemodialysis, which had not been done before. They agreed. Christian did his own hemodialysis, and over the next several years, he was able to train other patients to do it. Eventually, the entire unit runs. 50% of the patients do self-dialysis. What you're seeing in this picture on the right is the head nurse there, Britt Marie Bonk, and in the middle is Patrick Blomqvist, another patient who now co-directs the unit. The self-dialysis unit is run by a patient and a nurse. This was heard by a nephrologist in Waco, Texas, Rich Gibney, who picked it up and brought it to Waco. And I just want to show you a quick video of Rich talking about what he learned. Is it possible to play that video? Will it work?
We brought Christian Farman, the patient, who in Sweden was the first person to do self-care or empowered dialysis, and in the head nurse, Britt Marie, to Waco, Texas. And the first thing they said was, would you be willing to turn the machines to face the patient and allow them to touch the machine? It's been hunkered down for 40 years that I've been doing it. It was come in, sit down, be quiet, don't touch anything. So you can imagine, basically they're helpless, they're learning how to be more helpless, they're bored, they're depressed, and we kind of missed that whole point and thought that was a good way to do it. Until we saw empowered or self-care dialysis. We call it empowered because that's what happens, is that you say to the patient, you can do the hunker down, or you can do empowered, which is control, freedom, independence. That's what you get. And with that, you get the benefit of optimism, joy, and hope. And all the patients immediately say, sure, that would be dynamite, that'd be great. And yeah, the data, basically it was stunning. I mean, it was kind of beyond belief that the hospitalization rate fell to be 1/2 the hospitalization rate that had been before, because patients were involved, engaging in their treatment. And then finally, the mortality rate dropped 1/3. The staff, again, they have to make a radical change. They're going from being worker bees, where they run around the clinic doing everything, to becoming teachers, coaches, trainers, cheerleaders, and it's a profound experience.
There's a new era here. It's coming fast. And this era of co-production, where the patients and families become our complete partners in the pursuit of quality, safety, and the experience they want, I think is a fundamental change. Lastly, widening the view of harm. What's happening here is really important, and that is a blurring of the boundary between the topic of safety and the topic of quality itself. I think they are the same thing. And as we get more mature now, transform our organizations, become more partners with patients, more and more kinds of things we could call injury or harm will surface. We need to stay open to them. It's going to get broader. Absence of dignity is harm. I don't have time to show you the video attached here because I'm running long, but when a patient doesn't feel respect, we've harmed them. That's measurable. Here's work going on at the Beth Israel Deaconess Medical Center. They're rather difficult to read here, quality scorecard, but you'll notice the last category is dignity and respect related metrics of quality. We need to go there. And to track what Andy said, the absence of equity is harm. We are in a highly inequitable society, still with the vestiges of racism actively among us. It's time to end it. The consequences of that, just like a pressure ulcer or a aspiration pneumonia, kill people. And if we don't map the resolution of inequity, the end of racism, into the American agenda for the improvement of health care, we will be acceding to harm that we should not accede to. And so it's time to broaden to that level. Just like we have the data on ventilator pneumonias, just like we have mechanisms for preventing central line bacteremias, we know what to do about unequal treatment. We have the science behind us, and it's time for us to use it. I'll mention IHI's recent white paper on pursuing equity. If you want to have an early start at it, go there. Good news, this is the most frequently downloaded resource on IHI's website, I believe, in our history. So the interest in equity is growing. This is where we're headed. Congratulations on what you've done. There's much more to do. Focus on what goes right, not just what goes wrong. Get proactive. Think of the whole system. Build transparency beyond anything you've thought of yet. Begin to incorporate the ideas of people like Christian Farman and those millions of patients and families out there ready to work with us instead of being the objects of our work, and broaden the view now. I am stunned by what you've accomplished. CMS is a major force and a trustworthy partner for the continual improvement of health and healthcare for all Americans because you have done it. I am deeply grateful to you as an American and in awe of what you've been able to accomplish so far. Thank you for what you've done, and there is much more now to do.
Ladies and gentlemen, please welcome back the one, the only, Dennis Wagner.
Thank you, Dr. Berwick. That was very helpful, very moving, and we're very grateful to have had you here this morning. It's been quite an extraordinary morning. I'd say it's been quite an extraordinary 3 days, and I want to recognize someone who has been integral to the organization, the design, the planning, the execution of this meeting. And if I could just call Monique Necho to the stage. Very good, she's behind the curtain. So, Monique is new to the Quality Improvement Group. How long have you been with the Quality Improvement Group?
I think since September.
Since September, she accepted the accountability for organizing this entire meeting. The contract for it was signed at the end of September. This wonderful young woman shows initiative in everything she does, and as many of you in this audience knows, when you make a request of Monique, she always says yes. Like, it's extraordinary. But somehow, you have said yes to everyone that I've encountered in the design of this meeting and have done just a remarkable job, and I want to thank you on behalf of everyone here. Good job. Now, I said yes 2 weeks ago I foolishly said yes to a request 2 weeks ago that came from Monique and others to conclude our conference. I'm sort of reminded of what CDC Director Tom Frieden said yesterday when he said it's a mistake to follow Patrick Conway onto one of these stages. I don't know if you realize it, but I'm now following Andy Slavitt, Jean Moody Williams, Mark McClellan, and Don Berwick. So I'm going to be very brief as we wind up, because in our work we wind up. We don't wind down, we wind up. This has been an extraordinary 3 days, and I think, at the beginning of the conference we talked about who we were, And we talked about we're QIOs, and we're hospital improvement innovation networks, and we're ESRD networks, and we're state leaders. And I think who we are is really, really important. And, you know, Don ended his remarks by reminding us who we really are, who we really seek to be. Trustworthy partners, major forces in the continual improvement of health and healthcare for all Americans. That's who we are. That is what we represent and who we seek to be. Now, I learned from Don Berwick when he was the administrator, he said something very, very sticky. He said, culture eats strategy for lunch. And I believe that our network of networks in quality improvement across the United States, we have begun to create for ourselves, I think, an extraordinary culture. And it's grounded in what you've heard already from Don Berwick. But I'm going to just name, I think, what are 6 qualities of the culture that we have been creating together as we do this work of continuous improvement. One of the key elements, transparency. Inclusive of and committed to the patients that we serve in the improvement work that we do. This is something that Andy Slavitt has really, I think, brought to the forefront with the quality payment program. Serving the clinicians, providing exceptional customer service to the physicians, the nurses, the nurse practitioners, and the other clinicians that we serve in our work. Celebratory. You know, we've done a lot of celebration here, and the wonderful thing about that is we celebrate each other, but we celebrate the results that we're generating together, and I think that is quite extraordinary. 2 other elements of our culture, the culture that together we're creating. We're partnering with each other across boundaries. We see that over and over in the networks. I saw it over and over again throughout the 3 days of this conference. It's what we aspire to, and it's working, and we're modeling the very behaviors that we're asking nursing homes, hospitals, home health, clinical practices, dialysis facilities to do with each other. We're modeling it here at the national level, and there's no better form of influence than what you do. What you do counts for more than what you say or what you teach. And when we model that kind of seamless partnering across boundaries, we're doing what we want the clinicians and the organizations that we serve in the field to be doing. Lastly, we're results focused. And I wouldn't be true to who I am if I didn't talk very briefly as we close here about the what, about the aims and the results that we seek as we go forward. We heard just a few moments ago from Dr. Berwick, and I'm so grateful that you're putting out the aim of a 20% overall reduction in patient harm by the end of 2019. That means that 115 harms per 1,000 discharges drops to 97. It's a bigger goal than the goal that we've already achieved, a 20% reduction in overall harm. 140,000 clinicians moving to advanced alternative payment models through the hard work and the dedication of the Transforming Clinical Practice Initiative, along with 6 other aims that guide that initiative. 75% of the nation's nursing homes working to improve quality, and the first 2 years show that we're very successful in this work across 13 different dimensions of care in nursing homes. 90% of clinicians eligible for the quality payment program choose to participate and avoid that penalty. These are some of the aims that we're committed to. It's extraordinary work. Now, in closing, I want to acknowledge something that we heard, I think, from all 3 of our speakers this morning, and that we've talked about through the course of the conference. We know that change is coming. We've had a lot of change these last 6 years. We've been at the forefront of participating in that change, and in many cases, leading the changes in the transformation of the U.S. healthcare system. And based on the election, I think we should expect that more changes are headed our way. Now, one of the best ways to thrive in a time of change is to foster in ourselves, in our partners, and those that we work with, resilience. And Don, I noticed that in one of the books that you recommended, a commitment to resilience was one of the key features. And resilience comes from known places. We can foster resilience in ourselves by focusing on 2 key things in particular. Purpose, grounding ourselves in purposes. And there is no higher, more noble purpose than the one that we share in this work. And a second is partners, people who have our back, people who work with us, who team with us, that we know we can count on. We've got extraordinary partnerships across this room. I've benefited from extraordinary partnerships with people like Jean Moody Williams, Kate Goodrich, Sherry Ling, Debbie Hattery, Dr. Paul McGann, my close working partner every single day. Those two things, purpose and partners, we have in abundance. And I think that over the course of this meeting, we've been able to experience the abundance of purpose and partners that we have. And I would say as we leave here today, take that purpose and take that partnership back with you. You're going to need this resilience if we're going to thrive through these times of change that are surely headed our way. I have the greatest confidence that we'll be able to do that and that we'll do it together. Thank you for being here. Safe travels.